following podcast is part of a certified educational activity titled From Migraine Recognition to Relief, Improving Outcomes with Patient-Centered CGRP Antagonist Strategies. Access the entire activity and complete the post-test at peerview.com/PXM860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Jessica Ilani. I'm the director of the Georgetown Headache Center and a professor of clinical neurology at MedStar Georgetown University Hospital in Washington, D.C. Thank you for joining us for this unique case-based educational activity titled From Migraine Recognition to Relief, Improving Outcomes with Patient-Centered CGRP Antagonist Strategies. Our goal for today is to improve your skills in recognizing and diagnosing migraine quickly. We're going to equip you with the latest evidence surrounding CGRP antagonists for acute and preventive migraine care and provide guidance on strategies to elevate your migraine care to optimize patient outcomes. So let's get started. Migraine is defined as a moderate to severe headache that is often seen as throbbing, one-sided, and made worse with physical activity. Migraine, though, is not just a headache. It comes along with photophobia, phonophobia, and nausea or vomiting, and oftentimes in the midst of an attack, a patient will notice that their skin and their scalp feels very tender and sensitive, something called cutaneous allodynia. For a portion of people with migraine, they'll experience something called an aura, which is a neurological symptom that comes prior to the onset of migraine. For a smaller portion of patients, they have very frequent migraine attacks, and this is called chronic migraine. That's when a person has more than 15 days a month of headache, and at least 8 of those headaches are migraine-like in nature, and this is occurring at least 3 months in a given year. Now, migraine is a very common neurological disorder that affects quite a large number of people. When we look at the world population, 1.4 billion people are affected with migraine. We know it's more commonly seen in women, and it's the number 2 cause of years lived with disability, especially in younger women. And that's because a day living with migraine is equal to a day where you're unable to move out of bed or function. So it's like being quadriplegic. In 2016, there were 4.3 million office visits because of migraine and 4 million emergency department visits. We know that migraine can impact different populations in different ways. African American and Hispanic individuals are 25% and 50% less likely to receive a formal migraine diagnosis compared to white patients. African American patients are less likely to be prescribed acute migraine medications, and Latino patients are less likely to receive guideline-recommended preventive therapies. Individuals who have lower income are more likely to experience higher rates of migraine and struggle with reduced access to care. Those living in rural areas have longer distances to travel for health care and might really have trouble finding a headache specialist in their region. They might have limited health literacy and have tremendous stigma and income lost because of missed workdays related to migraine. Another significant burden within the disease of migraine itself is that our clinical trials can lack diverse population representation, and so this sometimes can limit how we can apply clinical trial findings in practice. Let's move on to talking about making a better diagnosis of migraine in clinical practice. To do this, we're going to talk about Mariana. Mariana is a 34-year-old Hispanic woman who's coming in to see you today to talk about her headaches. She has a 4-year history of headache, and her attacks, they last about 30 hours when they're untreated. They're occurring 5 to 7 times a month, and she has some nausea with her attacks and light sensitivity. Her headaches really impact her ability to function. Sometimes she misses work, about 1 to 2 days a month, and sometimes she has a hard time when she's trying to meet up with friends or family. English is her second language, so she's had some negative experiences when meeting with prior healthcare teams to really advocate for herself. In the past, she's tried ibuprofen and acetaminophen, but these really haven't helped relieve her symptoms. So, do we think that Mariana meets the criteria for diagnosis of migraine? Do we think that she needs imaging or any kind of further testing to make the diagnosis? We use an international classification system called the ICHD-3 to make a diagnosis of migraine. Just looking at the basic migraine diagnosis, we have migraine with aura and migraine without. To meet the criteria for migraine without aura, you have to have at least 5 attacks in your life, lasting 4 to 72 hours if untreated. That includes not taking any over-the-counter treatments, not resting, not trying to put an ice pack on your head, or anything to take care of the attack. Symptoms have to include at least 2 qualities of pain, so unilateral, pulsating, moderate to severe in intensity, and made worse with physical activity, and at least one of the following associated symptoms: nausea, vomiting, or both, or photophobia and phonophobia. So if we take a look at Mariana, she had, a handful or more of attacks in her lifetime that were unilateral, moderate to severe, worse with physical activity. So she has at least 2 of those pain features. She has nausea and she has photophobia. So she meets the criteria of migraine without aura. For migraine with aura, you have to have at least 2 attacks in your lifetime with at least 1 reversible aura symptom. Most people with migraine with aura will have visual symptoms, but they can have other symptoms as well. They also need to have the presence of at least 3 following features: that the aura symptom spreads gradually over 5 minutes, that if they have more than 1 aura feature, one will start and then stop, and then the other will start and stop. Each individual aura symptom lasts anywhere between 5 to 60 minutes. At least 1 aura symptom is unilateral. If it's more than 1 aura symptom, that one of them is a positive symptom, like seeing flashing lights. And then the aura is accompanied or followed by a headache within 60 minutes. This can be a little bit tough in clinical practice if this isn't what you're doing day in and day out, like I do. So is there an easier way for us to make the diagnosis? There's something called ID Migraine. This is a rapid screening tool for migraine, primarily designed for primary care, but can also be used in the emergency room setting. It's pretty sensitive and specific for making a diagnosis of migraine, and it's 3 simple questions that can be asked before you even see the patient. Are you nauseous when you have a headache? Do you get light sensitive? Do you have to stop what you're doing at least one day in the last month when you were having one of these attacks? If they say yes to at least 2 of these questions, most likely this person's having migraine. There's also a visual aura rating scale, which can be used to distinguish migraine aura from other visual disturbances. You're trying to scale them to see if the duration of symptoms was between 5 to 60 minutes, if it gradually spread over 5 minutes, if they had an area of vision loss, if there were zigzag lines, and if it was unilateral visual symptoms. And to find that out, you just ask the patient if they covered one eye, would the symptoms still have been there versus if both eyes were open. If they scored more than 5 points, most likely you're looking at aura. So when do we think about imaging a patient who's having migraine? So would this patient that we saw in clinical practice need to get an MRI? Well, routine neuroimaging is not generally recommended in a patient who has a headache that's consistent with migraine and their neurological exam is normal. We instead look for something called red flags. A mnemonic to try to remember this is called SNOOP. Another one is SNOOP 10. So you're looking for systemic symptoms like fever or weight loss, history of cancer, neurological signs and symptoms. During the exam, they're presenting with confusion or there's neurological changes. They describe the headache as coming with a seizure or focal deficits. Thunderclap, sudden onset headache. This is concerning and requires immediate imaging. New onset headache after the age of 50. You're concerned about a tumor or temporal arteritis. There's a change in pattern. Someone used to have an occasional attack when they were younger, and now it's every day. Or there's a change in severity or clinical features. A person comes in who's had a history of migraine without aura, suddenly has an aura for the first time. This might be a reason to obtain imaging. Other red flags that you think about: positional related headache. So someone who has a headache only when they're sitting up, not when they're laying flat. Headache worse with sneezing or coughing or exercise. New onset headache in pregnancy or right after pregnancy. If they have a painful eye. If they have a headache after head trauma, or if they're having headache after overusing medication. So now that we've talked a little bit about how to make that diagnosis of migraine, let's talk a little bit about treatment. And we're going to focus here on some of our migraine-specific treatments as CGRP antagonists. We're going to talk about clinical evidence and then move into equitable implementation. So going back to Mariana, remember this is our woman who has a 4-year history of migraine without aura, who's tried over-the-counter treatments and they haven't been effective. Where does this really take her? This is her first visit with us. She's tried over-the-counter medicine, but she's never been on migraine-specific acute treatment. She's not really getting much relief with over-the-counter treatment, and she has some nausea. So what are the things we need to think about, and how do we really walk through the evidence and different treatment options with this patient? So first, it's important to know that when it comes to acute treatment, we have quite a number of different options to offer this patient. And since she's tried over-the-counter treatments, we really should focus in on prescription items, especially things that are migraine specific. So here we're taking a look at information on what has established efficacy for acute treatment in migraine and probable efficacy for acute treatment in migraine. And when we look at this information, we can see that there are some non-specific options like NSAIDs and some combination treatments like NSAIDs and caffeine. On the probably effective side, we have things like antiemetics like prochlorperazine and metoclopramide, both things to think about since she does have some nausea. But we also have treatments that are given IV, so these are good options for if she was in the emergency room, like ketorolac or magnesium. But for someone like this patient in the outpatient setting, we really want to focus in on first having a conversation about things like triptans or ergots and thinking about that nausea. So maybe thinking about a non-oral option. So thinking about this is a good idea, but we want to also walk through side effects, potential complications with medications, and having a good sense of what her comorbid issues might be. So if we're thinking about triptans or ergots, we want to make sure that she has normal blood pressure and she doesn't have any vascular risk factors. If we are thinking about a prescription NSAID, we have to be cautious about GI issues and cardiovascular problems. But again, in her case, I would really focus in on migraine-specific treatment options. It's important to realize that acute treatment is really important for people with migraine. Every patient needs an acute treatment option, and their acute treatment option should be optimized. If their treatment doesn't work and they can't get rid of their attacks, they're at increased risk of developing chronic migraine over the course of 1 year. And we also know that insufficiently effective acute treatment can actually lead to the patient taking more acute treatment, and then they end up with medication overuse headache. So let's move on to talk about some of our newer acute treatment options that target CGRP. These are called gepants, and there are 3 of them available. 2 are oral tablets. One is an oral dissolvable tablet, one is just a tablet, and then there's a nasal spray. So rimegepant is our oral dissolvable tablet that can be used as needed once a day. It has a longer half-life of about 11 hours, so it's good for somebody who has very long attacks. Ubrogepant is an oral tablet that can be taken as needed and can be repeated once within 2 hours if needed. It is available in 2 dose options for patients. Zavegepant is a nasal spray, also with a longer half-life, is only a single spray in 1 nostril is needed and doesn't need to be repeated. So something to think about in a patient like Marianne, that she is having nausea, we might again think about a non-oral option. So thinking about a non-oral triptan, DHE, which tends to be nasal or injectable, or maybe even zavegepant, which is a non-oral gepant option. So looks like she's got some options that are in front of her, and we can talk her through that. So looking at the data for the gepants, we can see that they're about same when it comes to efficacy from freedom from pain. Within 2 hours, close to 20% of patients are having freedom from pain, and that's compared to 12% in the placebo. And when we look at freedom from most bothersome symptom, this is their one identified associated symptom like nausea or photophobia or phonophobia that's associated with migraine, that we can see rates close to 40% of freedom from most bothersome symptom at 2 hours compared to placebo, which is around 25 to 31%. This, we see that it can be an effective treatment regardless of rimegepant, ubrogepant, or zavegepant. If patients have tried a triptan before, if patients are on a preventive therapy, and they generally are safe to use frequently over time. In fact, a study looking at rimegepant showed that if rimegepant was used frequently over the course of a year, that patients can actually have been shown to see improvement in frequency just by treating their acute attacks, not something we see often with a treatment like a triptan, which is known to cause medication overuse headache if used too often. So let's go back to Mariana and think about if we've discussed acute treatment options with her and she's made a decision about which way to move forward. Is that enough? Do we need to talk about prevention? Remember, she's missing 1 to 2 days of work a month. She's having impact on her social life, and her attacks are pretty frequent, 5 to 7 days a month. So she's got some disability, high frequency, and these are lasting quite a long time. So is she a candidate for prevention? Do we want to have that conversation with her? And if so, what are the therapies on the table? And should functional impairment be a reason that we have this discussion with her? So the goal of preventive treatment is to reduce attack frequency, reduce attack duration, improve the patient's function, and reduce disability. We also hope that we can reduce the use of acute treatment, and so that they're at less risk of overuse of acute treatment, and that they can be more effective and be more present at work and not have to take a lot of as-needed treatment. And this helps reduce patients' overall cost and reduce the escalation in use of acute treatment. This also improves the patient's health-related quality of life and reduce their headache-related distress and psychological symptoms. Many patients over time develop extreme anxiety about when that next attack will occur. And thinking about the next attack becomes something that really overwhelms them and adds a lot of burden. So if we're able to reduce that stress, that can really be a big move forward for a patient. It is important, though, for patients to understand that prevention is not a cure. And so in clinical practice, when speaking to a patient about prevention, it's important they realize that they will still have some attacks. And that's why acute treatment is necessary to have on hand, and not to expect that all attacks will go away at all times. So here we're just looking at a chart that talks about guidelines about when to start prevention. So we used to only really start discussing prevention when a patient was having 4 to 6 migraine attacks per month. But we started to realize that disability really needs to play a role in that conversation. So while we definitely will start to offer patient prevention when they're having 4 to 6 attacks per month, we start that conversation a lot earlier nowadays when they're having 3 attacks a month and severe disability, but even down to 2 attacks a month and severe disability. So if a patient's missing 1 to 2 days a month of work, that's pretty disabling. If they're not functioning, they're not going out, they're not meeting with family, and they're starting to become isolated because of their disease, acute treatments aren't working for them, and they're starting to get very anxious about their disease burden, we're going to start to talk about prevention. There are many options available to patients for migraine prevention. Some are migraine specific, some are not as specific, but have good evidence. And our level of evidence continues to grow. We're going to double down and talk about the anti-CGRP category of medications and really focus on treatments that are migraine specific that target blockage of CGRP. And these are our monoclonal antibodies, eptinezumab, arenumab, fremonizumab, and galcanezumab, and our CGRP receptor antagonist, or the gepants, atogepant and rimegepant. Here you can see that they're all dosed slightly differently, with eptinezumab being an intravenous infusion, dosed quarterly, arenumab, fremonizumab, and galcanezumab being a subcutaneous monoclonal antibody. Arenumab and galcanezumab are monthly dosed. Fremonizumab can be dosed as 1 injection once a month or 3 injections every 90 days, so there's some flexibility with the dosing there. Atogepant and rimegepant are both tablets. Atogepant is a daily tablet that is FDA approved for both episodic and chronic migraine. Rimegepant is an oral dissolvable tablet that's used every other day and approved for prevention of episodic migraine. Let's take a little closer look at the data, especially at how soon you might see results with some of these newer treatment options that are migraine specific. Our traditional options like topiramate, amitriptyline, propranolol, the data there would show that it can take 6 to 8 weeks before we start to see improvement in migraine frequency. Whereas with some of our newer treatments, we see the same kind of reduction in migraine frequency, if not a little bit better, with our episodic migraine trial showing a reduction of about 4 to 5 days less per month compared to placebo at about 3 days less per month. But we can start to see change as soon as the first week for a majority of the patients, and this was statistically significant and significant compared to placebo. That's really exciting for patients to hear, especially when they're struggling with significant disability, that there's a chance they can see change happen as soon as the first week. Here we're looking at data at the CGRP monoclonal antibodies at the percent response rates. So in clinical practice, this is very relevant when talking to patients. And if we were talking to someone like Mariana, she might want to know, what's the chance that someone like me would respond to treatment? And here you can say, depending on the dose and depending on the type of treatment, there's a 40 to 50% chance that after the first dose, you can have a greater than 50% response. That's half or more reduction in the number of migraine days you're having, and that's significant compared to placebo. Let's talk a little bit about how we might make different decisions depending on a person's comorbid diseases. So what if Mariana had coexisting cardiovascular disease like uncontrolled hypertension or hyperlipidemia? What would we do in those situations? Well, it would be important to think about how her acute plan might change and also maybe how her preventive treatment would change. We know for the CGRP antagonist that secondary safety outcomes from phase 3 and phase 4 trials have demonstrated no significant increase in MACE findings. No clinically meaningful changes in blood pressure or heart rate have been reported. And safety profile has been consistent even in migraine patients with cardiovascular risk factors. We also have very specific findings for each of these treatments, look in post-hoc analysis of pivotal trials, looking at cardiovascular risk and safety. So we see, if we look particularly at those with moderate to high cardiovascular risk, in Ubrogepant studies, that was about 11% of patients. There was no change in efficacy, and the treatment emergent adverse events didn't differ. If we look at eptinizumab, which was the IV infusion given quarterly, that about 13% had about greater than 2 cardiovascular risk factors. And the same thing, there was really no change in treatment and emergent adverse events and no meaningful impact on blood pressure or heart rate. And when we look at Rimegepant, very similarly, about 12% of patients had greater than 2 cardiovascular risk factors, and 7% of patients had a moderate to high 10-year cardiovascular risk. And again, what they found that the most common adverse event was upper respiratory infection, which really didn't change regardless of their cardiovascular risk. So it is important to note that based on the pivotal trials, cardiovascular risks didn't really impact side effect profile or cause any cardiovascular issues. But this isn't necessarily the case with some of our other treatments for migraine. So for triptans, we know it's a vasoconstrictive medication, and we have to be very careful in patients with uncontrolled hypertension. In those who've had a stroke or who've had MI before, it's not a recommended medication. We also now know with NSAIDs, we have to be very careful. It's associated with MACE, especially those with cardiovascular risk. And so we don't want to use it in patients who've got uncontrolled blood pressure either. In ergotamines, it's also a vasoconstrictive drug and contraindicated with cardiovascular disease, hypertension that's not well controlled, or peripheral vascular disease. And so you have to be a little bit cautious with these medications, monitor the patient carefully, and also go through their risk. What about cardiovascular considerations with other migraine treatments that are for prevention? Well, with our tricyclic medications, we worry with higher doses for QT prolongation and arrhythmia. With our SNRIs, there's a risk on label for hypertension. Sometimes there's some benefit with our medications if the patient has hypertension or has cardiovascular disease. You could consider starting a beta blocker or ACE inhibitor or an ARB. These have level A evidence and can be helpful for cardiac disease as well. And then there are medications that are generally neutral, like onabotulinum toxin for chronic migraine or some of our anti-epileptic drugs. So what about a patient who is family planning? So what if Mariana was considering becoming pregnant, or she primarily had migraine around her menstrual cycle? Does this really change how we're making decisions? Are there any data to support the use of CGRP antagonists in menstrual-related migraine? And how does that compare to other available therapies? And then when does the benefit of CGRP antagonism outweigh the risk of treatment during pregnancy? And which agents would be thinking about best during these particular cases? So we do actually have some data looking at CGRP monoclonal antibodies in those that have menstrual-related migraine. And what we see is that the efficacy in perimenstrual and non-perimenstrual periods are comparable and that these treatments work. And they consistently have migraine reduction across the menstrual cycle, but across the month as well. And so when a patient comes in who has menstrual-related migraine and we're seeking a good preventive agent, we have data here showing that our CGRP monoclonal antibodies are effective for these patients. And I know that having that dialogue with them is really nice. They like to hear that there are options that have been looked at specifically in those types of cases. When it comes to the GPANs, the CGRP receptor antagonists, we know that they're effective in women, and there is some evidence for short-term perimenstrual prevention, though it is very limited, and there are trials that are looking at this time. We know that ubrogepant is effective and well-tolerated for acute treatment during the perimenstrual time period. That means a woman who happens to have her menses and has a migraine around that time, that ubrogepant was as effective as treating a migraine attack at other times during the month. So it is important to realize that a patient who has migraine is carrying some risk with pregnancy, that migraine is associated with increased risk of preeclampsia, peripartum mental illness, and preterm birth. So it is important that this discussion happens, whether it's with the OB-GYN or it's happening in the neurological office or primary care, and that there's a discussion that management of migraine as a person is trying for pregnancy and in the first trimester where migraine frequency might not yet decrease is important. The first-line treatment for migraine during pregnancy are non-pharmacological strategies like behavioral interventions, deep breathing exercises, trigger avoidance, lifestyle modifications. But when you do need medications, there are some studies showing that acetaminophen might be helpful, especially when combined with metoclopramide. And then if this is not effective, sumatriptan may be a reasonable option. In the second trimester, you may think about using an NSAID, but this should be avoided in the first and third trimester. You should avoid opioids and ergots. And if you need to add medications along, metoclopramide and diphenhydramine may be options to add along. What about using an anti-CGRP agent during pregnancy and lactation? So the FDA labeling says that there's insufficient data to support the use of CGRP antagonism during pregnancy, so most are not recommended. There are pregnancy registries available, and there has been a little bit of published data showing that a patient who has been exposed to some of the CGRP monoclonal antibodies early in pregnancy and then stopping use, there haven't been any negative fetal outcomes, but these are very small numbers. For lactation, it's unknown if an agent is secreted in the breast milk, so you really need to consider the risk versus benefit. But lately, there's been some studies looking at ubrogepant that has minimal transfer into breast milk. There's some studies on rimegepant showing minimal transfer, and now atogepant also showing minimal transfer. It's important to note that these are small studies. They have about 12 patients in each study, but it is still something that is there for patients to consider and an option to think about. When it comes to a woman who's considering pregnancy, we usually will recommend stopping the CGRP monoclonal antibody about 5 to 6 months prior to trying for pregnancy. But if they're on a G-pant, like a Atogepant or Rimegepant for prevention, they only need to stop at about 5.5 half-lives before starting for pregnancy. So that's about 55 hours. So give or take, 4 to 5 days. So a very short interval of time. And so we often will consider a G-pant instead of a CGRP monoclonal antibody if a woman indicates the desire to become pregnant over the next year. So how do we navigate the idea of addressing healthcare disparities, avoiding medication overuse headache, and choosing therapy in someone who has nausea and vomiting? I think these are things that we all actively need to think about. But looking at Mariana's case, having an interpreter help her with these conversations is going to be important if English is not her primary language. Finding an acute medication that's actually helpful for her and getting her on a preventive treatment that is effective and well tolerated is going to be important. Thinking about non-oral options in a patient who has nausea and vomiting is also very important because it's hard to take an oral treatment if you're feeling really nauseous, and sometimes that might cause patients to delay acute treatment, which will just make the migraine attack last longer. How are other ways we can improve and individualize migraine care? Well, we'd like to talk to our patients about some lifestyle changes they can make to try to sleep and wake around the same time, a little bit of mild exercise every day, whether that's walking or stretching or yoga or, just dancing, anything they enjoy doing. And they don't have to join a gym. They can just do these activities around the house. It's important to try to manage their stress. So meditation, deep breathing, journaling. There are many different ways they can do that. And then keeping a regular diet. We don't recommend a particular migraine diet, but trying to eat healthy, eating at regular intervals. This is going to be really helpful in order to help the patient live a healthier lifestyle. We don't talk too much about migraine triggers, as that more and more evidence suggests that they're not as many triggers as we think they are. And then triggers tends to imply that it's the patient's fault. And trying to avoid that self-blame is really important. Keeping a migraine diary that really tracks the frequency and duration of attacks and what they took to treat is very helpful. And then working with the patient to set goals is important as well, whether that's reducing frequency, whether that's using less acute treatment, whether that means making it to the next big family event. And really talking through that visit to visit is important. We also want to make it easy to choose a preventive treatment. So not only do you want to review the options and look at patient comorbidities, you want to talk about pregnancy. You want to talk about birth control. If they're not planning pregnancy, how are they protecting it against it? You want to talk about taking the medicine at the same time of day and really looking through their patient history about things they've tried before and things that they tolerate and their burden of other medications. So to conclude, the safety and efficacy of acute and preventive migraine treatment are critical. Patient-reported outcomes are an important element in treatment decision-making. CGRP-based medications are well tolerated and are easy to start in the primary care setting. That brings our discussion to a close for today. I hope you've enjoyed this activity and found it really informative and useful to your practice. I encourage you to access the supplemental program materials. Thank you so much for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Pfizer. To access all materials for this activity, visit peerview.com/PXM860.